Okay. All right, let's get restarted on this. Now, if you found the last lecture sort of like, boring, and yes, you have a question? Right. You're talking about this right here? Okay. There's two portions of the way the brain does things. It either activates, okay, or it inhibits an action. Okay? If it activates an action, it causes another effect. Okay? In this case, the release of antidiuretic hormone or the increase of thirst. Okay? If the brain is, on the other hand, inhibited by stimulus, it then causes the decrease in release of antidiuretic hormone and the decrease of thirst. Okay? This mechanism, when it becomes activated on this side, okay, is a negative feedback mechanism. It's shutting down the mechanism. Okay? Versus this one on this side is the activator that causes the antidiuretic hormone to be released and the thirst to be increased. Yes? Okay. I see. They both cause activation. It just depends. So that's really not a good terminology. Throw that one out. Just obliterate it off your sheet. They both cause activation of the brain, but one is an inhibitor and the other one's an activator, is what I was trying to get you to understand. Okay? All right. I'll change that on my slide. Now, when we're talking about all this stuff, especially when we talked about the electrolytes and the water content, a lot of the students, they look at this and go like, well, I really don't get all this stuff. Why is it important? Okay? If you don't understand about sodium and its location and potassium, where it's at in the cell, then when we start talking about pacemaker function and how neurons begin to work, okay, and how the electrical potential is generated, it will not make sense. So you have to sort of understand that these compartments and their different concentrations of these electrolytes is what gives the cells the ability to form electrical patterns, okay, or electrical activity. So your body is really trying to regulate that milieu at a constant environment, which is what the kidney is responsible for to a certain degree. And this comes down into the discussion of sodium and chloride balance. And I'm going to go into this a lot more later on, but just know that I'm going to give you the basics here first. Okay? Sodium is really not regulated directly by antidiuretic hormone. Okay? Antidiuretic hormone really regulates water content and water shifting back and forth. What actually regulates sodium, on the other hand, is aldosterone. Okay? And aldosterone is not released by the pituitary system at all. It's actually released by the adrenal cortex. Okay? What basically the adrenal cortex tries to do is if you see sodium levels beginning to drop off, it increases the reabsorption of sodium to try to maintain. And as a consequence of this increase in sodium concentration, it pulls water back in, okay, because water follows where the salt is. Okay, so the way the body tries to regulate indirectly water concentration inside the intravascular space is by aldosterone, by helping pull back sodium. Okay? Now this whole mechanism is actually rather complex. And the reason I have you learn this now is because I'll ask it again in course number 2, which is physiology. And then we're going to go into pathophysiology and then coexisting, and we're going to hit it 3 times. So by the time you're finished in your first year, you should have this down really well pat in your brain. Okay? So if you understand it now, then it'll be easier as you go along. Now, what actually regulates aldosterone to a certain extent is also the renin-angiotensin system. Okay? and I'll show you what that means in a minute. The renin-angiotensin system is a system that's inside the kidneys that releases a molecule, an enzyme called renin, which eventually causes the activation of aldosterone, which then also causes the sodium to be reabsorbed at that time. Okay? Sodium is your primary extracellular, not anion, but cation, so make sure you change that. It's the cation, not anion. Okay? This is cations for a positive charge. Anions a negative charge. Now this is what I expect you to know for your test. You have to know this cascade phenomena. Okay? This is the renin-angiotensin system and includes the aldosterone in this pathway as well. Here's the aldosterone. Okay? This portion here has to do with the kidney. Okay? And the green arrows that are going to this box are activators. That's what actually causes the release of renin. So there's many different sources that will increase the renin levels. Sympathetic input, okay, so a sympathetic discharge will cause an actual increase in release of renin. Things where you see a decreased renal blood flow will also stimulate the release of renin. Okay, so decreased perfusion to the kidneys will increase the renin production. Also, things that will also cause stimulating variables such as nitric oxide, the macula densula, cyclic AMP. Certain diuretics will also induce renin release. Essentially, emergency medications or hormones that are being released by the adrenal medulla, epinephrine and norepinephrine, will also increase renin production. And that kind of sort of makes sense because if those things are being released, you can anticipate that you're going to be losing a lot of body fluids because you may be hemorrhaging, and that's why they're being released. Early part of the day also is important for increased renin production. So this is actually in a circadian rhythm. And when you stand up, it also increases renin production. What renin basically does is when it gets released from the kidney, it causes a cascade event to take place. And it's actually an amplified event. So for every one renin molecule that you get released, it causes 100 molecules to be processed in an enzymatic process. That enzymatic process breaks down a molecule called angiotensinogen. Okay? Angiotensinogen breaks down into angiotensin 1. Now, angiotensin 1 basically circulates into your renal vein, and then it goes out into your bloodstream, and that has very little or no effect. Okay? So it does not cause vasoconstriction, doesn't do anything. Okay? It actually then travels through to the pulmonary circulation, and once it travels to the pulmonary circulation, you have another enzyme there that converts that molecule via ACE, which is angiotensin converting enzyme, into angiotensin 2. Okay? Now that's really important because if you had an active angiotensin 1, it would cause pulmonary vasoconstriction, which would induce pulmonary hypertension, okay, which is something you don't want to have. So the lung basically is protected from this effect because it converts this angiotensin 1 into an active product, which is angiotensin 2, and by that point it goes into the venous side and it doesn't really have an effect on pulmonary circulation pressures. Okay? Angiotensin 2, though, will have vasoconstricting properties, okay, once it gets into the arterial side of it. So systemically, it causes an increase in vascular tone. There's only 3 things that regulate your blood pressure: sympathetics, this angiotensin 2, which is renin-angiotensin system, and the last one is high doses of vasopressin, which is, of course, ADH. So those are the only 3 mechanisms that control blood pressure. The angiotensin 2, as it's circulating and causing its vasoconstricting properties, also approaches the adrenal cortex, and it induces the release of aldosterone. Okay? And when aldosterone is then stimulated, it causes the increased reabsorption of sodium by the kidney, which then causes more water to be pulled back into the kidney, increasing your intravascular volume. Okay? The other things that will actually directly stimulate the release of aldosterone by the adrenal cortex, besides the angiotensin 2, are elevated levels of adrenocorticotropic hormone, hyperkalemia, and hyponatremia. Okay? So those are the three causes of what releases increased levels of aldosterone. Now you ask yourself, well, why is it that hyponatremia will cause that? That kind of makes sense. I mean, it's aldosterone is causing sodium to increase in concentration. So that sort of makes sense. If your sodium levels are beginning to fall off, that would be an activator. But why hyperkalemia? That's the one that most people get confused about, and they always forget. Most people say, well, why wouldn't it just be hypokalemia? What's the byproduct of high workload? If I were to make you run around the block 100 times and then draw your blood test, what would you think you'd find in it? Lactic acid. Very good. What else? High levels of potassium. Okay? Because one of the things that your skeletal muscle is doing is not only is it causing fast depolarization with sodium channels, but it's repolarizing the cells, the skeletal muscle, by draining potassium out. Okay? So the potassium levels begin to increase, which is a way of telling the body, I'm under stress. Okay? So hyperkalemia will basically tell, hey, increased water reabsorption because we're under a tremendous amount of workload here, where mostly you're sweating a lot or losing a lot of volume. So if you increase the aldosterone levels, you'll retain more water and hopefully keep it inside instead of draining it out via the urine. Okay? Now, the other thing that also controls the actual water content in your body is a compound called atrionatritic peptide. Okay? Atrionatritic, okay? If you look at the word, it's a uretic. What does that mean? It's a diuretic. Okay? So it means that this drug is actually going to cause sodium wastage, which then is going to cause what? Diuresis. Okay? It's going to lose sodium and then lose water with it. Okay? Why would the body do that? Why would the body have a system? One system is basically to hold water, and the other system is to let water go. Okay? Why do you think it's in the atrium? Right. It protects the heart. The reason for it is to try to protect the heart from getting too much preload. If the atrium begins to dilate too much, then atrionatritic peptide or atrionatritic factor gets released in very high amounts, okay, which then induces the person to diurese rapidly. Okay? Now, one thing you have to understand is that under anesthesia, when you put positive pressure ventilation on somebody, what happens to the preload return back to the heart? It decreases. It decreases tremendously. So what do you think the atrionatritic peptide release is going to be like? It's going to be very, very low. Okay? And if it's really low, the only system that you can have activated at that point is the renin-angiotensin aldosterone system. So the water content is going to be held. And then you'll see the urine output go to 0. Okay? And then you'll start giving this person a lot of fluids, not realizing that the reason that the person is getting this issue is because you're giving too much tidal volume to the patient. And you're talking about as much as just a 50 cc change in tidal volume can make a huge difference. If you're delivering 800 cc's to an individual and they only really want 650, just by dropping it down to 650, all of a sudden the urine output comes back without having to flood the patient with fluids. Because trust me, even if you give a ton of fluids in that patient, what's going to happen still? Unless the atrium begins to dilate, the urine output doesn't increase. Okay? You'll see this happen when you work in the operating room. And if you see that a lot of your cases that you're seeing a very low urine output, and then at the end, when you're letting the person spontaneously breathe, you look at the urine bag and go like, man, where did it all come from? Okay? It's because you're excessively giving too much tidal volume in that patient. Okay? So some people have the habit of being really big on tidal volumes, and they tend to do that, overdo it. So the way you notice that the person's doing is by watching the urine output, it's very limited, and at the end, when this person's spontaneously breathing, then the atrium will dilate from all the fluid shifting back in, and it causes massive releases of atrionatritic peptide, and then causes a nice diuresis to occur in a matter of seconds. Okay, so it's rather impressive. Okay. Now there's another mechanism that's also releases high amounts of this natriuretic peptide, which is the brain. Okay, the brain does this at the last possible minute when it's about to herniate. So that's not something you want to see. If you see all of a sudden that somebody who has a closed head injury, all of a sudden you have a massive amount of urine output coming out, it's because the brain natriuretic peptide is being released to try to decrease the ICP pressures. It's trying to drop the intravascular volume and hopefully decrease the person's chance of herniating their brain. Okay? Less frequently that you see is the kidney produces a drug or hormone called urodalantin, okay, which is very similar and acts like a natriuretic peptide. All work basically to decrease the blood pressure by increasing sodium and water excretion. Now, sodium chloride and water balance can be classified based on tonicity as either being isotonic, hypertonic, or hypotonic. Isotonic things are basically total body changes with proportional electrolyte and water change. Things that are isotonic volume depletions are things like hemorrhaging. Severe wound drainage can also cause isotonic volume depletion. And persons that have been excessively sweating or excessive diaphoresis can also induce an isotonic volume depletion. On the other hand, if you have isotonic volume excesses or are from excessive fluid administration, hypersecretion of aldosterone, and in drugs like if you give somebody cortisone, will begin also to increase the levels of aldosterone as a consequence. Okay? The way you remember this is to think about where is aldosterone being released? Adrenal cortex. What's the first 4 letters here, or 5 letters in this word cortisone? Cortex. Okay, so it's a drug that's actually causing activation of cortical releasing substances, which increases aldosterone. Okay. Hypertonic alterations or imbalances result in increased osmolarity either by an increase in total sodium or a decrease in water. And that's really important for you to understand. Make sure that you get that little statement. It's not only just an elevation in sodium, but it could be also due to a loss of actual water. Okay? It basically ends up leading to intracellular fluid dehydration because water starts flowing out into this interstitial and intravascular space to try to make up for this effect. Okay? Things that can lead to a hypertonic extracellular fluids compartment are things like severe hypernatremia. So if you give somebody hypernatremic solutions, like 3% normal saline, things like that, you can induce this issue. Or you can get what's called hypertonic hyponatremia, which is where you lose your total body water as well as losing sodium as a result. This is rare. This is usually due to some kind of poison or to excessive amounts of sugar in the bloodstream. Hypertonic hypernatremia can also be seen where you see serum sodiums reach as much as high as 147 milligrams per liter. It leads to a significant intracellular dehydration. And usually the cause of this is due to excessive sodium intake or excessive water loss. The hypertonic hyponatremia is rare. It usually indicates other positive molecules, which I was telling you about, poisons that can occur. It displaces water volume into the extracellular space, and it basically decreases the sodium concentration. The examples of this would be a patient who's getting, let's say, hyperlipidemia. This can be seen in children if you give excessive amounts of propofol. Okay, why propofol? It's a lipid carrier. The actual medication that's in it is not the actual white stuff. The white stuff is a lipid that actually holds the drug in place. But if you give it to kids for prolonged periods of time, it'll induce this hypertonic hyponatremia, and the lipid levels will rise so much so that these kids will actually get almost like embolic phenomena from it. Hyperproteinemia can also take place. Again, that's very rare. And then hyperglycemia is a much more common cause of this. So a diabetic ketoacidosis or a patient who's in very high blood sugars in the 500 can induce this situation. As for your hypotonic alterations, it's from decreased osmolality. It causes hypotonicity or hyponatremia, such as a hypoosmotic hyponatremic patients with having sodiums of less than 135 milligrams per liter. These people become increasingly confused and combative. And the danger of this is that patients that run low sodium levels is they can have prolonged anesthetic effects. Okay? They don't wake up from the anesthetics very well. Remember, the electrolytes are critical in the brain to actually maintain electrical activity. So if you start losing your sodium, you start losing your gradient. So in other words, these cells cannot fire appropriately. The actual requirements for anesthesia decrease under hyponatremia. So the max value of your anesthetics, which we'll talk later on, actually decreases. Okay? Causes of hyponatremia can be due to pure sodium deficits, okay? Or usually most of the time it's due to water excesses. Okay? What would be the most common cause that we think of water excess? Very high levels of antidiuretic hormone. Okay? ADH levels are very high. So under stress conditions, you know, the person will develop hyponatremia from just ADH excesses. What's the danger of not knowing the following? Okay? Every once in a while you'll see somebody come in and say, okay, the sodium is 125. Should you take this person in the operating room? And the answer is, well, it depends. If it's really chronic and they've really tried to treat it, nothing's really can be done, then you just got to be careful and not try to, and hopefully you don't have a lot of fluid resuscitation, it's not going to be a problem. But if the person is going to be anticipated to have a very prolonged surgery with a lot of bleeding and you have to give them a lot of sodium replacement with normal saline, there's a possibility that you may reverse the sodium too fast. Okay? In the 1960s and 1970s, women that were having deliveries that began to hemorrhage were being given D5W as their main IV source. And every once in a while, people wouldn't realize that they would give them 2 to 3 liters of D5W, and they would develop severe hyponatremias of 110 or 115. The mistake that the physicians made at that time was that they tried to reverse this quickly. Okay? And if you reverse it quickly, it leads to a disastrous effect called central pontine myelinitis. Okay, let's break down this word really quick. Central, which means it's the central nervous system. Pontine, which means it's in the pons, which is a portion of the brainstem. Okay, and myelinitis. Okay, lysis of the myelin sheath is what that means. Okay, so you're taking all the cortical spinal tracts, which means that the information that's traveling from the cortex all the way down to your spine, okay, and you're demyelinating them. That's a terrible situation to be in because the person now is totally awake, can open their eyes because the cranial nerves are still intact, okay, but can't speak, okay, can't move their arms or legs, and is basically immobilized for the rest of their life. Okay, it's called a lock-in syndrome, okay, and it does not get better. Okay, so that's catastrophic. So one of the things that you cannot see is you cannot let a patient reverse their hyponatremia that fast. You got to resolve it very, very slowly. Okay? Right here is the pons area. This is where the demyelination would take place. This is a nice picture showing you the actual myelination is gone. Okay? And as a consequence, this person is locked in for the rest of their life. It's catastrophic to say the least. Now, water excess can also cause this delusional hyponatremia. Okay? You can correct this by basically diuresing the patient, but again, you should do it slowly over time. Do not try to change it too fast. Okay? Both intracellular and extracellular volumes, in this case, are usually very much increased, and they develop significant signs of hypervolemia, which is congestive heart failure, pulmonary edema, all those things that would you expect. Next molecule, which is potassium. Potassium is one of those molecules that you really have to know very well, because if you don't understand it, you will start seeing the detrimental effects, which is hyperkalemic arrest, or significant arrhythmias from hypokalemia. Potassium is by far the most important intracellular cation. Okay? It accounts for 140 milliequivalents, 140 milliosmoles per liter, or equivalent to, in milliequivalents per liter, of 150 to 160 milliequivalents per liter. Okay? The major function of potassium is that in cells that are actually sending electrical stimuli out, it's there for repolarization. Okay? Without potassium being properly functioning, it loses the ability for the cell to repolarize. Okay? Now what I've done for you is, let me just get out of this real quick. Let's see if I can